Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
Happy New Year, everyone. Wow, can you believe it's 2024? Where in the hell did 2023 go? And how did it go so fast? I want to thank the audience of the Pod of Inquiry for all of the huge amount of support that we've received over the last year. We've really been so blessed to have had so many great guests and episodes over the first 3 seasons. For this week's episode, I'm running my conversation with Dr. Sandeep Biswal as a reprise because of the massive interest it generated upon the first airing back in season 2. I believe the imaging techniques presented by Dr. Biswal in this episode is truly the wave of the future for pain management. This next year promises to be a very exciting one, and there are so many great experts willing to share their expertise. I know we are all going to learn so much more in 2024. Please enjoy my discussion with Dr. Sandeep Biswal on this novel imaging technique for diagnosing the pain generator. All right. Good morning. I'm here with Dr. Sandeep Biswal, who is a visiting professor at the University of Wisconsin, and he has done some fascinating work that I came across about a year ago with a combined MRI PET scan of the sigma-1 receptor. And we're going to talk about that a little bit. But before we get into the weeds, so to speak, why don't you tell us how you got to where you are now with this imaging? Because I think that would be a very interesting part of the story.
Great. Well, I'm honored to be on here. Thank you for inviting me. I'm excited to share my experience. How I got to this point is perhaps I could probably speak a whole session on that. It's complicated, but it actually comes from a wonderful set of parents who really believed in me and had me really study hard in school and was been very, very fortunate to go to some of the most exciting schools, in my opinion, at least for my journey. So I studied molecular biology at Caltech and eventually went to Harvard Medical School to get my medical training. But along the way, I had a kind of interesting childhood. I was kind of picked on because I was the nerd in the school and, had the huge overbite with the big, thick glasses. And I didn't know how to dress very well. And I wasn't particularly athletic. So I got kind of picked on. So I had a chip on my shoulder growing up. And as I went through, fast forward to medical school, I found that patients suffering from chronic pain were the also kind of, unfortunately, if you will, kind of marginalized, bullied patients in the system. I mean, it was kind of shocking to see as a trainee how much we would all kind of culturally say it's not only challenging to treat patients with pain, but I just don't want to do it. That's like, was a very common denominator among trainees and, even faculty. Just taking on a patient with chronic pain was going to be impossible, if not just challenging. So I kind of felt for the chronic pain patient. And I felt maybe that's somewhere I can have an impact in my life. And so I've kind of taken it upon myself to do better by the patient and hopefully, if not cure their pain, hopefully at least get them to live a more manageable lifestyle and, at least lower their pain somewhat. What struck me in medical school was how poorly we understood it being such a dominant sensation or a way of experience of life. We know so little, and our ways to treat it and management are so archaic. We ultimately have this opioid epidemic, not mainly, but it's driven by the fact that we kind of give up on patients and then say, hey, take this drug that will at least remove your symptoms. We can't really address your symptoms or what's causing it exactly, but we can at least make you feel a little bit better temporarily, and then of course dangerously with this drug that will ultimately make you dependent. So I just thought we really need to really help this group of patients better than we have been. And so one of the things I thought, well, maybe I can diagnose pain better. So I try to put myself in the best position to get the incredible training by a bunch of incredible institutions and mentors. So I've been very fortunate that way, but it still struck me that the gold standard for imaging pain, if you will, was MRI, and it was a morphologic based measure of pain. And we now in the past 2 decades have shown that it's quite inaccurate. And if anything, not only inaccurate and insensitive to pain generators, it can have patients undergo unnecessary surgery. So now you have another group of patients who don't do well after surgery. Failed back syndrome is one of them, but a lot of patients suffering from chronic pain don't do as well as we would hope after a surgical procedure that has been based on conventional, standard of care practices. A lot of it based on, of course, on your physical exam and then morphologic imaging. So with my training in molecular biology, I kind of wondered, is there a better, more sensitive way? And so it turns out positron emission tomography is about 100 to 1,000 times more sensitive and likely more specific than MRI. And you could actually measure receptor density. So or ion channel density. So if you were able to measure the location of where the pain receptors might be highly concentrated, maybe that's one way to identify a pain generator. Or if there was a cluster of sodium channels that you were interested in that were pain relevant, then maybe that's another way to go after it. So you could design a tracer that would indeed look for those changes in densities in your peripheral tissues, and that has been my hope, to identify peripherally where the actual pain is coming from. And then if you knew where that was and then maybe did some high resolution MRI, you could maybe figure out maybe a microscopic, if you will, or at least a high resolution version of where the pain generator is coming from, and potentially do something about it, either surgically or minimally invasively, or realize maybe there's just too many hotspots everywhere and this patient's probably amenable to medical therapy more than something local.
I think you make a very good point, and my practice is almost probably 95% chronic pain, and it's very hard to treat something if you don't have a really accurate diagnosis. And so that's why I'm so excited to talk about this technology today, because the way I look at pain, with the way that we've currently been, like as you mentioned, over the last couple of decades, it's like being in a dark room, knowing that there's some type of unfriendly animal running around in this dark room, but you don't really know what the animal is, and you don't really know where that animal is. And so what do you shoot the animal with? Do you shoot it with a BB gun, or do you shoot it with a big gun? And you have to match the treatment to the condition. And I think in one of your articles, it makes the very eloquent point is that, yes, MR is pretty good technology, but it's only tells us the form or the shape of a structure, and that doesn't necessarily correlate with it being the true pain generator. So am I getting that right? I think that,
Yeah.
with your technology, we're going to be able to treat pain much better. And, and then that speaks to the opioid crisis as well, because that's more of the shotgun approach, because we don't have, a pinpoint, really accurate diagnosis, but we have to do something to get them out of pain. Whereas if we can identify those pain generators, we might be that much more enabled to really dial in and say, okay, this is what needs to be done. And we'll talk about one of your case studies that I pulled with the lady who had the knee pain, which I thought was a fascinating study, clinical presentation. But with all of that being said, do you want to talk about the S1 or sigma 1 receptor? Because I think it's really interesting that you're able to, from your molecular biology standpoint, be able to look at this and say, what's going on a cellular level with these pain processes?
Yeah, absolutely. If you like, I can show you a slide on how it works a little bit.
Let me share the screen.
Yeah, all right.
I would love to do that.
Okay.
Technologically, it's not one of my strongest suits, but let's see if that'll work.
Okay. Yeah, that looks like it's working.
Perfect.
Then let me bring up my presentation. Here we go. I'll play it. Can you see the slide?
I can very well.
It says sigma 1 receptor imaging on the top.
Yes.
Great.
Got it.
Awesome. Okay. Well, briefly, it was previously thought to be an opioid receptor in the 70s, but then they quickly debunked that and then realized maybe it's something called a chaperone protein. What is a chaperone protein? Well, it's a protein that helps other proteins do their function. And in this case, the sigma 1 receptor is something that normally resides in the endoplasmic reticulum. So I had this cartoon that I drew up, and the light blue kind of structure here is the sigma 1 receptor, and it's hanging out in the endoplasmic reticulum in a somewhat quiet state of the cell, and it will buddy up against a number of different ion channels, including like NMDA, voltage-gated sodium channels, voltage-gated potassium channels, but most importantly, perhaps they're voltage-gated calcium channels. But in a quiet state, they're expressed at very low levels because the cell really isn't doing anything. Now, if there is some sort of painful injury, some really smart people at multiple institutes have found that it gets increased in copy number. So there's a upregulation in the expression level of the sigma 1 receptor, as well as all the ion channels. And then it helps carry these ion channels from the endoplasmic reticulum to the Golgi apparatus, and then ultimately up to the plasma membrane. And at the plasma membrane, it does a couple of things after even just carrying it. So it stays stuck to these ion channels. It can actually modulate the activity of these ion channels. So these ion channels now are extremely important in cell signaling in the inflammatory environment that it might have entered into. As well as on neurons, it plays a role to help create action potential. So it does multiple things for multiple cells. And but one of these things that it does is will modulate the ion channels themselves to the point that it's now called a receptor, because if you actually use a blocker of the sigma 1 receptor, it will help shut down that ion channel. So there are a number of companies that are exploring sigma 1 receptor antagonism as a potential analgesic. And there's a clinical trial right now for chemotherapy-induced pain, and it seems, at least preliminarily, it's having some benefit for patients who experience pain following chemotherapy. So there's some excitement about it being not only an analgesic, but also a non-addictive analgesic. So in animal studies, some of my colleagues, Dr. Chris McCurdy, has shown that it can actually treat pain and also do it in a non-addictive way. So so we're seeing a little more proof that its role in pain is quite important, not only to help modulate signaling, but also to act as potentially a primary analgesic. And so these are all the functions that it seems to have done with the work of a lot of people out there. So it can modulate opioid analgesia. It can modulate NMDA response, also modulate ion channels and affect plasticity as well as sensitization. And so in a pathologic state, if you have a lot of sigma-1 that's active, it can lead to pathologic pain. So that's what sigma-1 receptor does. Would you like me to show you some examples with patients now, or?
Yeah, let me ask you a couple of questions before you do that about this S1, S1R, sigma-1 receptor. It appears that this receptor plays a big role in a lot of different things as far as like cytokine signaling, regulation of how proteins are unfolded, and that it may even have a role in antidepressant and neuroprotective role. So just to distill this down so everybody can understand this, this receptor is upregulated in areas that are correlative to the amount of inflammation present in that area. Is that correct?
In the periphery, outside of the central nervous system, yes.
Okay, so peripherally, if we have a structure, let's say a tendon, for example, and I understand that these receptors are more preferential for neuronal tissue, right?
No, I don't think we still know that yet.
Okay.
That's what it was. It was initially studied that way. So for sure, it does seem to like nerve lesions, but we are also finding it in, at least at the macroscopic level, it's also engaging tissue that's not necessarily neuronal.
Yeah, and I saw in one of your articles that you published about complex regional pain syndromes that there were a lot of the intrinsic muscles in the foot that were abnormal from this expression of that receptor.
Exactly.
So we have an area that is problematic from a cellular level, and correlatively there is some there's some type of inflammatory process that causes an upregulation of this S1 receptor.
Yeah.
Okay. All right.
That's right.
Yeah. So let's get into some of your examples. I think that would be great.
Okay. Share my screen again. This is the, let me turn that on there.
Is this the ligand?
This is the radioligand, yes. So the cold compound is here, and then we stick this positron emitting isotope. So it is a source of radiation, but we use this radiation to our advantage by the ability of what's called a positron emission tomography camera, PET camera, to be able to identify and localize where this is because of this F18 moiety that's on here. And it's a small molecule, it's patent, it's in clinical trials right now. The interesting thing about this molecule is that this also ends up being an antagonist. So my colleague, as I mentioned, Chris McCurdy, who invented this molecule, he is interested also in potentially seeing if this will be an analgesic in its own right with a cold version of fluorine on it.
That's interesting because I was going to ask you that question after your presentation. Did you see any pain reduction in patients that underwent this imaging when they had this radioactive ligand?
Oh, fantastic question. Very insightful. So the FDA's definition of a radiotracer and an imaging agent is that it has to be administered at subtherapeutic levels. So it has to be 1/100th the dose that a drug will have any physiologic effect that's perceptible in a subject. So we'll well behold the therapeutic threshold of the drug when we inject it. Orders of magnitude. We're actually 1,000 times less than any perceivable fluctuation in physiologic parameters, including any kind of symptomatic relief that you may experience, unfortunately. But that's mainly because the FDA wants to make sure we're using this as a tracer and not a therapeutic. But we are interested in definitely developing this as a therapeutic down the line.
Excellent.
So one of the first tests we did was we wanted to take up what we call a positive example of where we think someone is having pain, and ideally the tracer should localize to the pain generating source. And so this gentleman had already had an MRI which showed that he had a schwannoma in his lower extremity and was likely the source of his lower extremity pain, which is where he marked on his diagram where he was hurting by this kind of blue line down his left leg. And then here's some images from the PET-MR, and I'll try to, I know it's a bunch of images, so I'll try to orient you. You don't have to read anything on the top, but in the event you want to look at it, that's totally up to you, but which you can do on your own time. But these are axial or transverse images through that schwannoma. There's that schwannoma, this little bright lesion. This is what we call a coronal image. So we're kind of looking through the front of the patient and then, but through their thighs, and you see this mass lesion that you see in the thigh. That's an abnormal structure, and that's in the sciatic nerve. And so the surgeon was pretty sure that was the reason for the patient's pain, given that everything else was negative. And so we did the PET scan along with this MR. And on the PET scan, you can see on this lower right image that it had taken up the tracer to a great extent. And there's a kind of numeric scale here showing how much relative to background. So background is, on the order of 0 to less than 0.5. And then this is upwards of 5 on the scale. So the tracer happened to localize to this source. And when we fuse the images, which these two images, the MR and the PET, are acquired simultaneously in a very, I would say, relatively unique scanner, as there's only maybe a couple of hundred in the country at the moment. But here in the fused image, which is automatically done by the computer, will show that that hotspot co-localizes with the schwannoma, sorry. And that kind of helped us indicate that this was perhaps the pain generator. And the patient subsequently went to surgery the next week and had this removed and had complete pain relief. So that was a kind of comforting outcome from this patient, and maybe it's showing you a positive control, if you will, that this tracer is doing what it wants to do. And then we asked, okay, if someone does have a nerve lesion that's non-painful, and they occasionally can be found. This gentleman is a different patient who had a sural nerve biopsy in their distal leg, just proximal to their ankle. And we see here on the MRI, they had sustained a neuroma following that biopsy. And right before the scan, I went up to the patient on the scanner and said, okay, can you show me where this neuroma is? And he showed it to me. You could actually see it under the skin as a small little nodule, if you will. And I mashed on it. He mashed on it. And he said, it doesn't hurt. And he says, I don't know why it doesn't hurt, but it doesn't hurt. And so I said, okay, let's see what it looks like on the scan. And on the PET scan, lo and behold, at the same location, we just don't have any uptake of that tracer. So this is a non-painful neuroma of the sural nerve. And this is the fused image. I mean, there's so little PET uptake, we just don't see anything. We just essentially see the neuroma. Moving on to some cases.
Sandeep, can we go back to that
sure.
for 1 second? Now, in general terms, anytime we would see a neuroma like that, you would just automatically jump to, all right, we need to take that out, translocate the nerve into, some muscle with whatever graft or however we want to do it that day. And this case would fail. And we may actually make the patient worse in this case because we played with something that wasn't a pain generator and maybe could make it a pain generator.
Exactly. Yeah.
Where was this gentleman's pain coming from then? Nothing else lit up, right?
He actually did have which I'm not showing here, unfortunately. He had foot pain. So they actually thought this was a pachymeria, but it turned out to be a highly inflamed posterior subtalar joint. So the joint was rip roaring and the talonavicular. So they're thinking about doing an arthrodesis. For some reason, his foot was extremely painful, and it was the hind foot.
I think this case shows the power of this imaging, right? Very apparently.
Yeah. Thanks. Yeah, I'm excited. Shall I show some other cases?
Absolutely. For
Okay.
sure.
So this is a gentleman who had sustained an athletic injury and ruptured his ACL, and was hopeful that he could go back to doing his athletic training. But unfortunately, after the ACL repair, had even worse pain than what he had sustained following the injury, and was quite upset and disappointed. He asked the surgeon, what's going on? I can barely walk. He was almost wheelchair bound. They had performed 2 MRIs, and the surgeon, and I think rightfully so, it looked like a post-surgical knee. It looked like a very typical knee that you would see with someone who had undergone an ACL reconstruction. And he said, I have nothing to offer you. I'm not going to do anything. And in fact, started hinting at the patient that the patient was crazy, and, maybe you should, just kind of deal with it. And the patient, of course, was extremely upset by this, having read the literature that ACL reconstructions are usually have a decent outcome, if not a highly favorable outcome. And so he's very disappointed. And so he was quite distraught, sought other surgeons, but then ultimately found my trial. And so this is a case of what I think is painful synovitis arthrofibrosis. But the patient here on his drawing describes, he just kind of scribbles, just kind of describing where his pain is located. Some in the back, a lot in the front here of his left knee. And one of the things I didn't mention earlier is we do a whole body scan, because if you have knee pain, it may not be your peripheral pain generator, may not be exactly in the knee, it may be in your spine, and you now have referred knee pain. So just as an aside here, to let you know, we do a whole body scan all the way from top to bottom, and making sure we capture every possible pain generator that might manifest itself. What you're seeing here is what's called a MIPT image. So it's not a slice through the patient, but it's a 3D volume. So all the images are kind of stacked on each other. But just to kind of give you an impression of how abnormal the symptomatic knee is, compare that to the contralateral knee, which is asymptomatic completely. Here's a bit of a zoomed in image, or a zoomed in slice, showing you quite robust uptake of the signaling receptor radiotracer in that location. Again, just to reiterate, the patient had 2 MRIs prior to this that were read as essentially non-contributory, meaning they were just post-surgical change, but nothing particularly painful specifically. And here's some PET-MR images. This is a sagittal, so we're kind of looking from the side. This is what's a transverse image. And then these PET and the fused image up in the upper right, showing you inside the knee, in front of the femoral condyles, at the level of the femoral condyles, there's quite robust uptake in something called the intra-articular fat, or Hoffa's fat pad. Also, there's some spots inside the intercondylar notch, and some spots behind or posterior to the knee. These are just other images, other slices and projections. Again, this is a sagittal. If I were to look at the MRI, I would agree with the surgeon. I would say nothing really remarkable at all. In fact, I don't see any abnormal edema that I would expect to see, at least as some sort of sign of inflammation on MRI is what we would see as edema or increased signal on this particular sequence, but I don't see edema or increased signal in any abnormal places here. This is the PET image showing you, for some reason, there's this focal uptake here in the posterior aspect of Hoffa's fat pad. So,
before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. Well, folks, if you are over 40 and you are not using a supplement to augment nitric oxide production, you should really think that. This molecule is absolutely imperative to health, not to mention its cardio protection. If you have any question on nitric oxide, I suggest that you go back and listen to the Pot of Inquiry, Season 1, Episode 3, for my conversation with one of the world's experts, Dr. Nathan Bryan. I never miss a day of nitric oxide supplementation. That's how important I believe it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett, all lowercase, at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration, and I'm certain you will be pleased not only for yourself, but all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see every one of those patients will be nitric oxide deficient. When they see this result, they will want you to start them up immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates.
So quite a bit of uptake of that tracer there. This is another slice. So here we're kind of in the middle of the knee, the kind of intracondylar notch level. So seeing quite a bit of uptake anteriorly and posteriorly. Ultimately, I just wanted to I get these kind of emails and texts from patients from them, just kind of, oops, went too fast there. He wrote before the surgery, I have excruciating pain. He wrote, he was asking me if I could really help him. And I was, of course, I'm going to help you. And he says, you are my primary physician at the moment. I mean, this is how frustrated he's asking a radiologist to help him out. It's sad. I mean, it's funny, not funny. I feel guilty giving you that responsibility, and I have no problems doing that. I just want to help these guys. And then that imaging, and I'm kind of cutting to the solution, I mean, the end of the story here, but I just thought maybe it might be interesting to kind of give you the context. And he had surgery for this, and I'll show you some results of that. He wrote, no pain, some swelling around the incisions, but no pain. Thank you so much. Thanks to you. I'm constantly getting better. You and Dr. Another orthopedic surgeon did miracle work. And then I should have written a quote here, but he's completely back to full strength and doing his athletic activity now. So why I wanted to show that is just kind of impress upon you. This top row of images is the pre-surgery MRI. Again, just to show you again how much uptake here is in the intra-articular space, showing you what I think is painful fibrosis. Again, he had 10 out of 10 anterior knee pain after ACL repair. He almost had to use a wheelchair to get around. And then this is after the surgery. So I tried to best represent the same exact slice that I could as close as possible. And again, that this was about 6 months after the surgery, showing you that uptake of the tissue that was seen before is now gone. And again, kind of correlating nicely with his complete symptomatic relief. This is that case you were talking about earlier, of the woman who had knee pain. This is not a picture of her, of course, for HIPAA reasons, but I just use it when I give talks to indicate a somewhat middle-aged woman. This poor woman had knee pain that came on, and the initial orthopedic surgeon thought you must have chondromalacia patella, despite MRIs saying her knee was completely normal. And subsequently, just empirically, they decided, okay, let's do a lateral retinacular release. So that is a surgery where they cut the joint capsule lateral to the patella, and hoping that the patella will have more mobility and not be restricted in its anatomic location, and therefore maybe give the patient some relief. But that did not help at all. The patient had no pain relief from that surgery. And then so the surgeon said, well, I can refer you to a quote unquote pain surgeon, which is basically a surgeon who will ablate or cut a nerve that supplies to the knee, supplies sensation to the knee. And the patient agreed to do that. And it worked for about 3 to 4 months after RF ablation of the common perineal nerve. But unfortunately, the pain came back with a vengeance, presumably because sometimes the RF ablation doesn't exactly sever the nerve. The nerve roots are still maybe intact or partially treated, and probably created even a more sensitive situation for that unfortunate patient. But it turned out it didn't. Her pain returned, and the patient then went on to see what she claims is about another 30 doctors, and went on antidepressants because no one could help her pain. And she said every day it was 8 out of 10 to 10 out of 10 pain. Every time she would get up or sit down, it felt like a knife going through her knee, and she had trouble walking on certain surfaces or walking downstairs. This is her MRI. And again, if I read this prospectively, I would have said this is a normal MRI. I'm actually showing you what the pathology is, and what the PET taught us what was wrong with this knee. But what's interesting, here's her, again, we do that whole body scan, hoping not to miss any possible sites of the pain generation. And in her area of symptoms, there's this small dot in her knee. There's some other uptake in other muscles, and I'm still trying to understand what that is. I suspect some of it might be some soreness that she may be having because she's favoring
compensatory.
Yeah, exactly.
Yeah.
So, and she did describe some soreness in other parts of her body. So maybe that's hopefully what we're seeing. And then this is just a zoomed in shot of her knee. Here's even more zoomed in shot. But this intracondylar notch has kind of a fierce uptake of the tracer compared to the contralateral knee. And so the first surgeon was agreeable at this sense. When he saw this image, he was like, oh, okay. I'll be happy to go take a look. And so he was happy to go in, and when he looked in there, he said it was extremely inflamed, and he removed all this inflamed tissue in there. And these are some of the things that patient left me with. So post-op day 30, her pain was 8 out of 10 to 10 out of 10. Now it was down to a 2. She was able to walk on grass. For 6 months post-operative. I actually emailed her on month 4 and month 5 and got no answer, and I was getting really nervous. And on month 6, she finally responded with this. That pain I had is gone now. I did physical therapy for a few months, and I had not had to take any medication for her knee since the recovery of her surgery. Since this started 6 years ago, I've never been able to say that. She says, I was hesitant to get excited too quickly because she had undergone 2 failed surgical procedures. So she just didn't want to jinx it. And so now the pain is gone. Thank you for finding it. 18 months post-operative. Hello, I wanted to let you know I have no pain. Leg is back to full strength. She got better. She had been suffering then that 8 years. The surgeon fortunately sent some tissue to pathology. And so interestingly, this is not a nerve. And so this is why I'm kind of, interested in what the scan is showing. It's showing lots of inflammatory cells in what was called a synovial lipoma. So he had, for some reason, a stalk with a big fat ball attached to it, and it was being whipped around between the cruciate ligaments in that part of the knee. And she probably was born with this, or over time developed it, and it got bigger and bigger and very irritated. This is in retrospect what we were looking at. So to us radiologists, this is just tissue that we just don't know what lives there normally. So this should have maybe been picked up, and now hopefully we'll pay attention to it now, this kind of finding. But it's not unusual to see such heterogeneity in this part of the knee. So that's why all of us, would have said this is a normal knee. This doesn't look like anything to us, and it's not particularly brighter than water, or as water. So that's why it doesn't really register with us, but that's probably what it was. Here it is in the axial plane and coronal plane. And we didn't do a follow-up PET only because we like to not necessarily give radiation to people if you don't necessarily need it. But what we did do is a post-operative MRI, and it showed removal of all this tissue that we were seeing earlier. So all this kind of rind of tissue with cystic areas is now gone. So that was kind of a nice outcome for that patient.
No, that's wonderful.
I'm happy to share more cases if you like.
Yes, I'd like to see. So before we go to the next case,
Yeah.
I think this illustrates something that I've learned dealing with pain patients. It's suddenly a lot. They get, like you said earlier, they get bullied. It's in your head. You just can't manage your pain. You're crazy. I mean, I've heard all these stuff. It's amazing how when you do find something that is their pain generator and you take care of it, how uncrazy they get so quickly.
Yeah. Yeah. Exactly.
I think that's one. Yeah. No, and this is really illustrative of the the lower extremity types of things that we see, and it's a blessing to have this kind of technology. But go ahead with some more cases.
Sure. Let's see. This is a 36-year-old male with back pain after a motorcycle accident. So it's a bit of a daredevil. He was dirt biking in one of the parks and fell off a cliff that was about 2 stories from where he landed, and he landed on his back. And so this is where his symptoms are. He had 2 important pain generators, one just off midline, off to the left, and then one way more lateral. These are extremely debilitating. Him being a very active person now is reduced to walking with these pain generators. This one's going to be a little more challenging to appreciate, but hopefully I'll do a decent job of explaining it. So what we're looking at here is a lumbar spine MRI, and this is a sagittal projection. So we're looking from the side, but then this one is a transverse projection through the area of interest through one of the lumbar vertebral bodies. He had sustained a fracture of what's called a transverse process. So you see a little gap here in this low signal structure relative to this one. There's a bit of a gap compared to the contralateral side, which is intact. It should have looked like this, but there's a gap. So we would call this a fracture of the transverse process at L3 in this particular case. And then here's the PET image, and the uptake is going all the way up to the fracture margin compared to the other side. So a little trick with this tracer, there are some normal physiologic areas which do take up the tracer. We're still trying to understand that. As you can see, there's some bowel uptake. It doesn't mean he has bowel pain. It just means there's some areas in the body which normally express a higher level of sigma-1 receptor. The marrow in the vertebral bodies is also another area, but it does so in a relatively intermediate level. So these brighter areas may also be potential pain generators, but we still don't quite understand. We're going to need to get some funding to do a big clinical trial to better understand it. But we do know where it's not supposed to be, and one of it is not so much in this pedicle in a robust manner. So it's getting up to that pedicle. What's interesting clinically is you can figure out where L3 is on his body and push on that spot, and he'll kind of jump every time you push on that fractured transverse process. But if you go down to L4, where he also has a fracture, and you push there, he doesn't jump. And lo and behold, the PET scan shows that it kind of looks symmetric to the asymptomatic side, and it doesn't really go up to the level of the fracture, which should be where this red arrow is shown here. So again, here's the fused image showing you the red arrow that the tracer doesn't quite get up to that fracture. So that's perhaps not a pain generator, even though we're seeing morphologically there is a fracture there. And then that would be kind of his left paraspinal pain. So we had an explanation for that. And then here are MR images through the trunk. So still at the level of the lumbar spine, but now kind of going out more laterally to where he was describing some pain. This is a coronal view through some of the soft tissues. And one of the things I haven't really said is how often the MR is negative, even on the MR that we perform in areas that we're looking at. So where this yellow is pointing out will ultimately, of course, be where the PET is positive. But if I look very carefully, I don't really see anything abnormal on the MR. And so what this PET is picking up is, of course, increased sigma-1 receptor density at this site. And you see, compared to the contralateral side and the subcutaneous tissues, there's a small focus of uptake here. And then here we localize it in the subcutaneous fat layer. So somehow he injured the fat there. And the thought is that maybe he has a really small neuroma in that site. Here's some zoomed in images. It could be this little bright focus is a small unnamed nerve neuroma in that location. And that's kind of close to the area of uptake, which may be giving him his sensation. Why this is important. Pain generator, it's a good question. I don't know why he has so much pain from this subcutaneous site, but maybe with movement, he kind of stretches the subcutaneous tissues, and that kind of angers maybe that neuroma that's in there or this area of inflammation. Of course, the brain is highly in tune with it, if you will, and so it doesn't like that. So one of the things we offered him was to come in and inject this area with steroid and anesthetic and see if that would kind of calm things down. So we did that on a follow-up visit using ultrasound guidance. So we used some of the anatomic landmarks that we were able to glean from the PET-MR and then use the ultrasound to get to that location. And then after the injection, we said, let's see if you can go test it. So he got Marcaine, which is a longer acting anesthetic, of course. And we said, go hike on the dish, which is this relatively popular mountainous trail that's about 3.5 miles long. And so he loves to walk on the dish, and that's what he, even to this, prior to the scan, he did every day despite all the pain. But he would kind of note, normally on a hike at the dish, his pain would kind of get up to a 5 or 6 on that site. And when he starts off before the walk, it's a 2. So it gets 2, and then by the end of the walk, it's a 5 to 6 on this very hilly route that he takes. And then at rest, even if he pushes on it right at that spot, it jumps to a 5 to 6. So those were his kind of pre-anesthetic injection pain measures. And then we injected him, as I said, with Marcaine at that site. So at rest, immediately he had 0. When he put pressure on it, it was still a 0. He did the 1 mile run in part of the dish and still had 0 right afterwards. So he was very happy. He normally takes about an hour or 50 minutes or so to walk that loop, but he did it that day in 39 minutes. So
Wow.
Much less pain, felt amazing. Couldn't help with the adrenaline. He had empirically 2 previous injections done at UCSF, not to belittle their contribution, but it didn't work. And I suspect because they just didn't know exactly where to go, how deep to, and how lateral to go, that sort of thing. And he said, he'd never been pain-free at that site for 8 months. So very excited by that result. So we're trying to figure out what to do with him as well. Maybe this last example here, this is, I was wondering if this could help patients with autoimmune painful syndromes. And this is an example of someone with Sjogren's disease who had the kind of dry eyes, dry mouth, and also just diffuse body pains. So this unfortunate individual had pain everywhere, marked here, and she had described multiple MRIs over the years that were not helpful and also read as negative. And as we talked, she felt she was going crazy herself. Already had experienced people calling her crazy, because nothing was showing up objectively with standard clinical measures as being positive. And so this is her PET scan with the sigma-1 receptor. So again, whole body image. In this case, we're capturing pretty much everything that she described as painful. And just to give you as a comparison, these are asymptomatic volunteers towards the right of the image, one in the middle and one on the right, just to kind of give you the degree of what normal patients look like. Now, you're probably asking, oh my God, look at all this uptake in the normal patient. Again, we do have areas of our body that have sigma-1 receptor normally. So the liver likes it, the bowel likes it, the lung likes it to some extent. And so we'll get uptake in there, and then the brain really loves it too. So we can talk more later about that, but this is kind of the normal picture on the same scale as this pain patient. So I want to make sure we're comparing, apples to apples here by placing the patient in the same kind of color scale as well as the range. So that's kind of what a normal patient will look like. But what I think is quite impressive is the extent of uptake in the periphery and then the trunk, as you can see. These are just kind of more slice images as opposed to the 3D image you just saw, showing you uptake in the various muscles in this unfortunate patient, showing quite robust uptake in all areas that she had complained of. What's again impressive to me is this is a pretty sensitive MR sequence on the lower left. It's sensitive to inflammation in water, but it looks completely normal in this patient. Okay, there's nothing I could say that's abnormal in this particular slice or in this coronal projection of this same patient. Notice the PET taking up all this uptake, which is one of the primary areas that she was complaining of, is kind of upper back, lower neck, in her back. That the PET is quite sensitive, as you can see, compared to MR. These are just the other areas, paraspinal areas that she complained of. And then this is down by her gluteus muscles, where she did describe some achiness. So also taking it up there. Again, pelvic areas, pelvic muscles, more gluteal in this case. Now in the thigh, so we're seeing axial images. Again, just impressing upon you on this, what they call the T2 flex. We should see edema in areas of inflammation, but the tracer is picking it up, whereas the MR is not. So what I do every day clinically is read MRs, and I can't help but think, what must I be missing for this unfortunate patient? So, but here the PET's picking it up. These are some of the emails again that I got from her. Amazing results. I'm so happy to get these results. It's good for me to know that where I hurt has an imaging correlate, and that is not all in my head, as has been suggested. As much as I am sad that my disease is so diffuse, I know that it is indeed real, and goes on to say, you've helped me more than you know. So,
and this would be a case, obviously, where you would have to try to get into some robust medical management for
exactly.
this patient.
Yeah.
That's really wonderful. I've got a couple of questions for you. So in previous conversations that we've had, you explained that you're now in a clinical study at University of Wisconsin for low back, I believe, right?
Yeah, we'll be starting hopefully soon. Mm-hmm.
Okay. But as far as lower extremity, we still can't get any patients into you. Is that correct?
Sadly, no. I mean, you can at Stanford.
Okay.
But unfortunately, I don't have funding for that one yet. I'm looking for funding. I'm trying to help some of the faculty there get funding for it, but unfortunately, we don't have funding. But it's open, meaning we could recruit today and sign them up if we had the money. I kind of hate even saying this, but if a big donor were to come in and drop a bunch of money for that effort, we could certainly use that money to help scan those patients. So,
well, I have a feeling that once this becomes more commercially available, there'll be a lot of necessity for it, because sadly, there are a lot of patients running around in chronic pain, and no one can figure it out. And again, I think it goes back to what you just illustrated with these case studies, is that, there's, quote, nothing there, but the reason there's nothing there is because our telescope just isn't powerful enough to see out far enough to see that there really is something there. So
Yeah, exactly.
yeah.
Yeah.
I'm excited about this technology, and I'll keep in touch with you. I have a handful of patients that I've been trying to get to you, and hopefully we'll be able to get them at some point in time. And I know they're not crazy because I know them pretty well. So I just have to figure out what's going on with them.
Well, I'd love to help you in your patients. So,
I appreciate that.
I'll have a lower extremity one pretty soon, within another 6 months.
If you would promise me that I would be one of the first people you contact, I will get you some patients right away, because
absolutely.
They're on this waiting list right now. In fact, I saw one that we had talked about last summer that I had tried getting to you while you were still out at Stanford. I happened to see her just last week, in fact, and they asked me, when is the imaging going to be available? It's like, well, I'm going to talk to you today, and I'll try to find out. But it's wonderful. Anything else you want to add to this? I think it's really fantastic. I'd like to have another discussion with you on peripheral nerve blocks and how they relate to helping us try to figure out what's the pain generator. But they don't have, in many cases, from a pain standpoint, they can be very poor predictors.
Yeah, I agree. Yeah.
Thank you so much for taking the time to come on with us today. And I'll put the contact information in the show notes if anybody wants to get a hold of you. And again, thanks so much. And
you can even include my cell phone if you want.
Okay. All right.
I give my cell phone to my patients and physicians. So
that's wonderful. Well, thank you so much. And I hope we can have another chat about this in the near future.
So too. Yeah.
Some more lower extremity examples as well. So
yeah, exactly. Yeah. Now I'm excited to work with you, and hopefully we'll get the lower extremity going soon. And so you'll get an email from me.
Cool. Thank you so much. I appreciate it.
All right. Thank you.
Several years ago, I chose Alpinion as my ultrasound brand of choice after years of experience and research into ultrasound imaging. In fact, I have 2 of their machines. Alpinion has incredible precision and penetration built into their technology that, in my opinion, is simply the best value in all of the ultrasound imaging space. They have several price points to meet your needs, and I can tell you definitively that you'll end up having to pay double to achieve the equivalent imaging quality from other top brands. That doesn't even account for the unlimited software updates and remote tech support included with no monthly fees. Right now, to show their appreciation for the listeners of the Pod of Inquiry, they're offering an incredible discount. Their portable i7 retails for $21,000. But you can get it discounted at most medical meetings for $19,000. But my listeners will get it discounted to $15,900. This has never been offered anywhere for the new portable system with the engine of a console system. Use code SBPOI to take advantage of this incredible offer. You won't be disappointed with Alpinion. I sure haven't been.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, podofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show, if used personally or professionally. It is the responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.